Yes. Good evening, everyone. We welcome you all to Ortho TV original webinar series on musculoskeletal MRI. Today, we have with us Dr. Aditya Daftary from Innovision Imaging and SportsMed. He is going to talk on ankle imaging. And we have two good foot and ankle surgeons. Both of my friends. One is Dr. Rajat Chopra. He's a consultant foot and ankle surgeon in Gangaram Hospital, New Delhi. And Dr. Abhishek Kini. He's a consultant foot and ankle surgeon in Mumbai, and he's attached to Lilavati Hospital and Rich Candy Hospital. So over to Aditya.
Thank you, Neeraj, for having me here. And so I thought today is our session on ankle imaging. And just to give you a sense for what we are going to do today, we are going to look at this in three basic sections. The first, we'll look at some basic MRI anatomy. We'll look at the common reasons for why we image the ankle. And I think through that, we'll understand how many of the common ankle pathologies we see are related to the ankle sprain. And then we'll talk about tendinopathy. I'm hoping that everybody can hear me just fine and the slides are projecting okay. Okay. So in terms of the anatomy, I think everyone is fairly familiar with the anatomic structures involved in the ankle. There are bones, which are essentially the distal tibia fibula, as well as the tarsal bones. There's articular cartilage, the key articular cartilage being that of the talar dome. There are the ligaments, which are the high ankle ligaments, which include the syndesmotic, the anterior and posterior tibiofibular. So this would be the high ankle ligaments, the syndesmotic, the anterior and posterior tibiofibular ligaments. And then the low ankle ligaments would be the talofibular, the calcaneofibular, and then the medial would be essentially the deltoid. And then towards the plantar aspect, we're talking about the spring ligament. So these would be the primary ligament complexes of the ankle. In terms of the tendons, posteriorly and medially, we have the FHL, the flexor hallucis longus, the flexor digitorum longus, and the tibialis posterior. Anteriorly, we have the tibialis anterior, the extensor hallucis longus, and the extensor digitorum longus. Laterally, we have the peronei, which are important. And other than that, we have the Achilles tendon and the plantar fascia. So if we look at the gross anatomy of this, if we look at the medial aspect of the joint, there's a whole bunch of names for this, but the primary complex we're looking at here is the deltoid ligament complex. Here you have primarily the tibiocalcaneal components here, and then you have the component that runs more anteriorly towards the tentaculum, which is the tibial spring ligament, which then continues down as the calcaneonavicular ligament. And then plantarly here, you have essentially your spring ligament, which is the static supporter of the ankle arch. So these are the primary medial stabilizers of the ankle. On the lateral side, on this anterolateral view, we can see high up here, this is the syndesmotic ligament here, and the thickening of the inferior portion of the syndesmotic ligament is what we call, the interosseous ligament is what we call the syndesmotic ligament. Then you have the anterior inferior tibiofibular ligament or the anterior tibiofibular ligament. And then below you have the anterior talofibular ligament. And this one is probably the most important one because that's the one that tends to get injured most often in ankle sprains. So that's a very important one to remember. And then you have the calcaneofibular ligament here, which runs down here, and you have other branches to it. And I won't get into those details, but primarily it's the calcaneofibular ligament that we're concerned about. So high up on the lateral side, syndesmotic, anterior tibiofibular, anterior talofibular, and then straight down the calcaneofibular ligament. Posteriorly, if we look, we have the posterior tibiofibular ligament, and this is kind of important for you to remember because if this is affected and you get an osseous avulsion of the posterior aspect of the medial malleolus, you know there's a fairly significant syndesmotic injury, and that probably automatically pushes somebody into a surgical category. Other than that, you have the posterior talofibular ligament, you have some accessory ligaments, and the posterior talofibular ligament is one that is seldom affected. And then if you look from posteriorly, again, you have the calcaneofibular ligament running down inferiorly. So posteriorly, we're primarily concerned about this posterior tibiofibular ligament, which is the really important one in terms of somebody when they have a high ankle injury. Once we go through this basic anatomy, let's see what this stuff looks like on an MRI. So the first thing we'll start up is high up in the ankle. These are axial sections, so you're almost bread slicing the ankle from the calf down. And when you look high up, you can see this band of tissue that is connecting the tibia and the fibula. And that essentially is the syndesmotic ligament or thickening of the inferior aspect of the interosseous membrane. Here is the syndesmotic area. You sometimes see two vessels running through it, but you don't see the band of tissue over here on this image. You see the band of tissue really nicely on this image. So let me just remove the pen mark and show that to you again. Okay, erase pen. Okay, so you see this band of tissue is essentially what we're looking at. This is the syndesmotic ligament. Um, from here, as you move further down a couple of slices, you will find this is the distal tibia, this is the fibula, and this band of tissue running across here and here are the anterior and posterior tibiofibular ligaments. So this would be the high ankle ligaments. Anteriorly, the tendons, you will find the tibialis anterior, the extensor hallucis, the extensor digitorum. And then therefore I tend to remember the anterior ones are anatomic. So anterior anatomic, that sort of sounds similar, so I can go with that. Whereas the posterior ones, you have the posterior tib fib over here, the tibialis posterior tendon here. Then you have the flexor digitorum longus, and then finally you have the flexor hallucis longus back here. So these are not so much in the anatomic way, and then because they cross at the knot of Henry lower down. Laterally, we have the peroneal tendons, and this would be the area of the retromalleolar groove, and you can see both the peroneal tendons squished together over here. Further posteriorly here is the Achilles tendon. So this is sort of the axial anatomy. Another little area to remember is this neurovascular structure anteriorly here, and this becomes important in patients who have anterior impingement. Let's keep moving down. As we move down, what we have here is you can see the posterior talofibular ligament here. So this is now going from the talus to the fibula, and that is the posterior talofibular ligament. As we go still further down, what you can see is the anterior talofibular ligament here. This is probably the ligament that you end up looking for most often, but it's also the ligament that probably, while it is injured oftentimes, it probably matters the least, because most of the time those injuries are managed conservatively unless somebody has chronic instability, but we'll talk about that more later. As we keep going further down, I think an important area to remember is here anterolaterally, where the anterior aspect of the talus, which is this contour over here, is just deep to the extensor digitorum longus tendon, and along with it a small little neurovascular bundle over here. And this is the area you need to remember to look at carefully, especially when you have patients with anterolateral impingement. Posteriorly here, you want to look carefully at the posterior aspect of the talus, and this tendon here is the FHL, and this is important for patients who have posterior impingement. These are the fibers of the deltoid, which you can see as a strand over here, and the tendons we've already talked about earlier. Okay, so that looks at the primary structures on the axial sections. On the coronal sections, as we go from anterior to posterior, you can see the talus coming down here, the navicular and the calcaneum, and the ligament that connects these two here is the calcaneonavicular ligament, or the spring ligament at its plantar aspect. And just superficial to that, you can see the knot of Henry, which is the tendons of the flexor hallucis longus and flexor digitorum longus crossing each other. As we go one section behind, what you will notice is the areas to look for are here the calcaneofibular ligament laterally, going from the fibula down to the calcaneum, and inferior to that, the peroneal tendons. Medially, you will notice the deltoid, which is the triangular structure here. Notice how interesting it is that the fibers of the deltoid have some striations within them, and that's normal. Below the sustentaculum here, you have your flexor digitorum longus and your posterior tibial tendon. And then here you have the talar dome articular cartilage, which is another common and important area for us to look at. So the coronal images are good for looking at the CFL, for looking at these tendons in the coronal plane, for looking at subfibular impingement, looking at the deltoid itself. As we keep going further back, we'll see the deltoid again, we'll see the peroneal tendons, we'll see the posterior talofibular ligament, and here you can see the flexor hallucis longus tendon running below the sustentaculum, and the flexor digitorum longus along with the peroneal with the posterior tibial tendon running along the sustentaculum. As we come posteriorly even more, it's important to look plantarly to get a good look at the medial and lateral, at the central or the medial and lateral bands of the plantar fascia. So this is a good place to look for plantar fasciitis. Okay. On the sagittal images, as we start more medially, you can see the posterior tibial tendon here, which is this black band of tissue, and you can see it connecting here to the navicular. So this is the posterior tibial tendon. This is the flexor digitorum longus tendon a little bit more posteriorly. As we keep coming forward, again, anteriorly, you'll see the tibialis anterior tendon here. And here, as you come even more medially, you'll see the flexor hallucis longus tendon posteriorly. As you come closer to the midline, you will see possibly this prominent posterior process of the talus, which can cause impingement of the stiada process. The talonavicular joint is important here. You can see this slender little neurovascular structure here. And this is where the talonavicular joint prominence can cause some impingement on this, and that leads to anteromedial impingement. This is your calcaneonavicular ligament in its cross section. So you can see this area. It's also an important area to look for coalitions over here, especially when you're concerned about calcaneonavicular coalitions. The Achilles tendon you can see in the back here towards the midline. And then this is where you're going to look for either prominent stiada process or the ostrigonum. So as we come further towards the midline, you can see that there's the subtalar articular cartilage and the calcaneonavicular cartilage, as well as the talonavicular cartilage. This is important when you start to make decisions regarding whether you're going to do a single, dual, or triple arthrodesis. The posterior superior aspect of the calcaneum is important to look at in patients who might have a Haglund deformity, and then look at the insertion of the Achilles tendon on the calcaneum. We'll talk about that later. This hole or gap between the talus and the angle of Gisson over here is your sinus tarsi, which is the area that makes you susceptible for sinus tarsi syndrome. As you come far laterally, what you will see is the peroneal tendons running below the fibula, and then you see anteriorly the peroneus brevis, the short guy is in front, and posteriorly the peroneus longus. So having gone through that basic anatomy of what we see on ankle MRI, I'm going to talk about why we image ankle instability and how MRI helps us do this. We're going to talk about what we can see and how that affects management. Okay. So when we think about why image an ankle sprain, I think of two reasons why we image an ankle sprain. Either an acute ankle sprain, and usually in this case, it is because somebody had an ankle sprain and it looks bad, or it is not getting better as quickly as one might have hoped. And in this case, we're concerned about what the degree of ligamentous damage is. So which ligaments are involved? Is it the high ankle ligaments, or is it a bad low ankle ligament sprain, or are the midfoot ligaments involved? So that's the one question we're asking. The second question is, what is happening to the osteochondral structures? So is there a talar osteochondral lesion, or is there some other kind of fracture which can make something look worse than it is? And that can tell us on what we need to do next. And then finally, to look at the peroneal tendons, or the tendons themselves, as to whether they are affected. Because remember, when you go into an inversion injury, the reflex action of the body is to sharply contract your everters, which are the peroneal tendons, which can then produce avulsion injuries at the base of the fifth metatarsal, or splits in the tendon, or ruptures of the tendon. So this is the reason why we would image an acute sprain. It's usually to determine whether somebody has a high ankle sprain or just a bad low ankle sprain. If it's a high ankle sprain, you may consider a surgical alternative, whereas if it's a bad low ankle sprain, you're essentially looking at a way to reassure the patient that they will get better. They may require physiotherapy, but it will take longer than normally expected. Similarly, with the osteochondral lesions, if you see a fracture, it's usually a non-displaced fracture, and you're trying to tell them that that's going to take its own time to heal. And then finally, the peroneal tendon. On the other hand, when you have patients who have recurrent instability, here you're trying to tell whether the ligament is intact or not, and what the quality of it is, and what the quality of the bone is, whether or not there is an osteochondral lesion and how bad it is, and then what are some of the dynamic changes. And obviously, all these help you in terms of determining whether you're going to go down a path of just passive reassurance, or whether you're going to take surgery. And if you're going to take surgery, what kind of surgical planning will you require for this? So in terms of assessing a patient who comes in with acute ankle pain following a twisting injury, the things that we want to look for very carefully first are to look for bone marrow edema and fractures. And for this, I recommend that you look at the blackest images that you can find on the MRI films, which have got fluid appearing bright. And on those images, we're looking for essentially areas of bone edema. And these commonly can happen by fibular fractures, which could be below, at, or above the level of the syndesmosis, which you know as the Weber type fractures, such as here or such as here. They may be subtle. Talar head impactions are fairly commonly seen. That's another thing we see. Sometimes we see anterior process calcaneal fractures, and then sometimes we also see some cuboid fractures. So these are other common fractures that we can see in these patients. So these are common areas where you see non-displaced fractures, which usually don't require surgery, but are a way of you're telling a patient that, look, it's a fracture, you're going to take 6 weeks to resolve, as opposed to if you had a regular ankle sprain and would take you just a week or two. So bone edema is quite important in telling you whether somebody requires surgery or we're going to leave them alone, and why they're going to take longer to resolve. Another common area of bone edema is the talar dome and the medial aspect of the talar dome, to be more specific. And this is an important area for impaction, and we'll talk about talar osteochondral lesions in a little bit. Once you've looked at the bone edema, the next thing you want to determine is whether the low ankle ligaments are involved or the high ankle ligaments are involved, keeping in mind that somebody who has high ankle ligament involvement is a potentially surgical candidate, whereas somebody who has a low ankle ligament involvement is less likely a surgical candidate. So if you think about the high ankle sprain, this is the normal syndesmotic ligament that we talked about earlier. You can see the slender band here. And you can see in this case how the syndesmotic ligament has gotten thickened and edematous and is a little hazier than on the other scan. So this is indicative of an intermediate grade syndesmotic ligament injury. Here's again an example of a bad syndesmotic injury with potential widening of the syndesmotic space. And along with this, what you can see here is the posterior tibiofibular ligament here, which is looking a little bit attenuated towards the talar attachment, the tibial attachment. And here the anterior tibiofibular ligament, which certainly looks like it's taken a bit of a beating towards its talar attachment. So this is a high ankle injury. This is an example of someone where you can see the normal anterior tib fib and posterior tib fib ligaments. And here you can see complete rupture of the anterior tib fib ligament from its tibial attachment. Whereas here's a case where you can see a posterior tib fib osseous avulsion from the base of the from the posterior aspect of the distal tibia or the posterior malleolus. So look very carefully when you have a patient with an acute injury to determine whether you think they have just a low ankle sprain or this is more likely a case of a high ankle sprain. So a high ankle sprain is a more significant injury with a different treatment plan. Once you've excluded the once you've looked at the bone marrow edema, you've determined whether or not there's a high ankle sprain, it's important to look for the low ankle ligaments. And here's an example of what the normal anterior talofibular ligament looks like. And this is probably the most commonly injured ligament. When you have a low grade injury, you can just have a little bit of stretching and attenuation like you have over here. You can have a significantly thickened and edematous injury in somebody who's got an intermediate grade injury, or you can have a clear disruption at the talar attachment here in somebody who's got a high grade injury. So these are the three different variations. So low, intermediate, and high grade injuries of the anterior talofibular ligament. And remember, when you lose the anterior talofibular ligament, along with it, you may lose some adjacent capsule. Sometimes with that capsule, you'll have extensive fluid and effusion going out into the adjacent soft tissues because of that capsular rupture. And that's why those ankles look really, really ugly when you see them clinically, even though they're just low ankle sprains. So possibly looking and assessing the ligament, the anterior talofibular ligament, will give you some sense of prognostication or explanation for why that patient's ankle looks worse or why that patient is not recovering as quickly as the last patient. Now, after this, we assess the calcaneofibular ligament, because in the spectrum of the standard inversion injury, once you lose the anterior talofibular ligament, the calcaneofibular ligament is the next ligament to become at risk. So here is an example. This is the distal fibula, and here is the normal calcaneofibular ligament. And here is somebody in which you can see this very thickened heterogeneous calcaneofibular ligament. And not only that, the patient has an infrasyndesmotic fracture or a small little non-retracted avulsion fracture of the distal fibula. So these are indicators that the lateral ligament complex has been involved in this, but it's the low lateral ligament complex. After the anterior talofibular and calcaneofibular ligaments are affected, the next set of ligaments to be affected in the typical ankle sprain is the deltoid ligaments. And it's important to note here that you have a deltoid ligament that looks normal, which is when it is triangular in shape, and you can normally see these striations within that ligament. Okay, and that if you can draw those striations with a pencil, that's relatively normal. as opposed to this situation where you can see a really heterogeneous deltoid, very bright signal, and that is an example of an intermediate to high grade deep fiber deltoid injury. Similarly, here you see that normal striated appearance to the deltoid ligament, and here you see the completely heterogeneous and inhomogeneous appearance. So this is how you know that the deltoid ligament is affected. And here in this patient, you can see that along with that inversion injury, there's an impaction injury at the talar dome, and we'll talk about that a bit later as well. So the fourth step in this assessment is to look at the deltoid ligaments. And again, involvement of the deltoid indicates a more significant injury, possibly requiring a different treatment plan, and also explains a worse appearance to the patient. Once you've done that, we turn our attention to the peroneal tendons. And here is the normal peroneal tendons. This is the muscle belly of the peroneus brevis here. And you can see more anteriorly the tendon of the peroneus brevis here. And more laterally, you can see the tendon of the peroneus longus. Here is an example of somebody where you can see that the peroneal retinaculum, which is essentially this band of tissue that overlies it, is quite thickened and edematous. And that is an example of a peroneal retinacular injury. In some cases, you can see that instead of the tendon being sitting behind in this retromalleolar groove, you can see that this is the retromalleolar groove here, but the tendon has subluxed anteriorly. And so you can see peroneal tendon subluxation. And then here you can see that normally you have the two tendons. This is the peroneus longus and the brevis here. But here you can see the peroneus longus has split, and you have the peroneus brevis that has gone in between them. And this gives you the famous, what is described as the Mickey Mouse sign. So if you think about the Disney character Mickey Mouse, you can draw the two eyes here and the nose, and that's essentially the Mickey Mouse sign that tells you that somebody has got a peroneus longus split. So just to show you, this is Mickey Mouse with his ears, and here you do not have Mickey Mouse with the ears. So these are some variations on what you can see with the peroneal tendons. Again, indicative of a different treatment plan, possibly if there's significant peroneal tendon involvement or if there's subluxation of the peroneal tendon. So when we're looking at the acute ankle sprain, again, to reiterate, we're looking to see, we will scan patients typically when things look bad or they're not getting better as quickly as expected. We're going to focus our attention on the ligaments, first to exclude a high ankle injury, and if it is a low ankle injury, to determine how bad it is, and also to look for midfoot ligament injuries, which we've not talked about yet. We look for osteochondral lesions, especially in the talar dome, as well as those non-displaced fractures we looked at in the distal fibula, calcaneal, anterior process of the calcaneum, cuboid, as well as the, those would be the common areas. And then we looked at the tendons, the peroneal tendon being the most important one. Now, when we have a patient with chronic ankle instability or chronic ankle sprain, then we're more concerned in determining which ligaments are involved, to what degree, and what is the degree of remodeling. What is the status of the cartilage? Because if we do a surgical procedure, if we do something, what are we actually salvaging? And then some dynamic changes. So when you have that ankle instability, obviously with that movement, certain adjacent structures become susceptible to injury, such as the anterior impingement, the sinus tarsi, as well as the posterior impingements. So when we're looking at a patient with chronic injury, again, this is the anterior talofibular ligament. You can see this ligament looking relatively thin and attenuated towards the fibular attachment. But as you get towards the talar attachment, it's really a tiny little strand. So you can tell that this quality of tendon is really poor, and the quality is worse towards the talar attachment. Here's another example of a markedly attenuated, almost thread-like anterior talofibular ligament. So in somebody with chronic ankle instability, one can tell the status of the ligament and how robust it is, as well as whether it is poorly remodeled or well remodeled, and if the changes are more at the talar side or the fibular side. Okay. And this sort of helps you decide whether you should reconstruct, and then what you're going to reconstruct, which side you need to reinforce more. Second thing is, when you have a patient with chronic instability, obviously the talar dome articular cartilage becomes compromised. And when you see compromise of the articular cartilage of the talar dome, it starts out as just bone marrow edema in somebody who's had an early injury. Gradually, there's cartilage loss, there's subchondral cystic changes, and sometimes you may have a more discrete osteochondral lesion. And when you have an osteochondral lesion, obviously the reason you're looking at this is to determine whether that osteochondral lesion is stable or unstable. So the first thing you want to look at usually is the status of the overlying articular cartilage. Now you can see the cartilage really nicely as this gray area that is between these two bones, this between these two red lines, this gray area, that is articular cartilage. And you can see here anteriorly, this bright area is the articular cartilage. And as you come more posteriorly, you can see here that there's almost no articular cartilage in this region. So we can tell the status of the overlying articular cartilage of an osteochondral lesion. We can also tell the interface between the osteochondral lesion and the native bone. So here we just have subchondral cystic changes, whereas here what you can see is a fairly discrete fluid line that separates the osteochondral lesion from the underlying native bone. And this is what we would call an unstable osteochondral lesion. So looking for this fluid line or looking for this clear separation between the osteochondral lesion and the native bone is very important in determining whether something is a stable or unstable osteochondral lesion. Now, once we move from looking at the status of the ligaments to looking at the osteochondral lesions, what we see in a lot of patients, so a lot of patients who present to you with signs of anterior and posterior impingement are just essentially a manifestation of ankle sprains that have been poorly managed. And when you have poor management of ankle sprains, not enough muscle recruitment or tendon recruitment, you tend to see an element of instability. And with that instability, you will see things like synovial thickening, bony proliferative changes, and some exaggerated effects of normal structures due to micromotion. So instability leads to micromotion, which then produces impaction on tendons, neurovascular bundles, and can also produce chronic degenerative changes within interosseous ligaments. So let's see how this happens. So if you have a patient with anterior instability, you can have gradual movement. Micromotion leads to the formation of bony spurs or osseous remodeling. So you can have an actual bony impingement because you have an anterior tibial spur and a talar neck spur, and therefore when you dorsiflex, these two pieces of bone will come in contact with each other and you will have bony impingement, or you'll find like a locking or a bony lock. But more commonly, you have some scarring that tends to happen anterior to the talus, as we talked about when looking at the anatomy, which can encase their anterior neurovascular bundle and impinge on the extensor digitorum tendon to produce anterior impingement, which could be neurovascular or which could be tendinous. And then sometimes you can have a small little bony avulsion, which can also end up producing mechanical obstruction or mechanical locking in the anterior lateral recess of the ankle joint. So anterior impingement can happen because of bony changes or can be neurovascular in its appearance. And here the choices are whether you're going to go with a surgical debridement or injection, or whether you're going to do an injection to determine whether a particular thing is truly the cause of symptoms, and then decide to go for a surgical debridement. Posterior impingement, on the other hand, is something we see very often in our fast bowlers, in footballers. And here it's because of plantar flexion and the posterior aspect of the talus, or the posterior process of the talus or the os trigonum, impinging against the traversing flexor hallucis longus tendon. So here is the flexor hallucis longus tendon, which would go like this. Here is the posterior process of the talus, and that's where those two structures would impinge. The simplest sign of seeing it is fluid along the flexor hallucis longus tendon sheath and edema along the posterior process of the talus. If you see these two things together and a patient has pain with plantar flexion, you can be pretty clear that this is a case of posterior impingement. Sometimes you will see an os trigonum, which is an accessory piece of bone sitting at the back here. This may or may not have bone marrow edema associated with it, which again will tell you that somebody has impingement. The impingement again being either upon the soft tissue or impingement of that bone itself with edema. In a chronic fast bowler, sometimes you can see marked remodeling of that posterior talus, and this is just because of chronic plantar flexion loading in these people, which can then also lead to posterior impingement. Okay, so again, for posterior impingement, you want an injection to confirm the diagnosis, possibly treat somebody early on in the disease, and then subsequently, if you want to surgically debride it, you want some sort of proof that that's going to help the patient. Once you have a patient with tibiotalar instability, what you will end up doing is you will end up loading your subtalar joints more. with that increased loading of the subtalar joints, what you end up seeing is some intrasubstance degenerative changes of those ligaments within the sinus tarsi. And with that sinus tarsi ligament degenerative change, you have edema on the surrounding neurovascular structures, which then leads to the neural effects of a sinus tarsi syndrome. Now, these degenerative changes can be just bright signal, as we see here, with some changes in the bone, or they may sometimes produce large ganglia that come out like this, as we're seeing over here. And if you were to think about this, this is not completely unlike seeing something like a mucoid ACL for that matter. So here we want to know whether the sinus tarsi syndrome is primary or secondary. And in my experience, it's almost always been secondary, because any patient in whom I see sinus tarsi edema or changes, they usually either have chronic ankle sprain or they have a flat foot. So we've gone to the second portion of this thing on where we deal with ankle sprains in the chronic stage. We're looking at patients who have recurrent instability. And in this situation, we're looking for ligament quality and affectation and remodeling. We're looking at osteochondral lesions in terms of where the osteochondral lesions are, the extent of involvement. And we even talked about a little bit about the stability and instability of osteochondral lesions. And then finally, the dynamic changes of impingement, which would be anterior medial, anterior lateral, posterior, or in the sinus tarsi. And again, those could be bony or neurovascular in their etiology. And all these things basically help you to confirm your diagnosis in terms of what the primary issue is and help you to plan what you're going to do next. Um, so we'll move on to the next section here, which is looking at tendinopathy. Tendinopathy is a common area that we encounter in patients, irrespective of whether they are in the ankle or anywhere else. And I think MR has a good role to play in understanding how we would manage tendinopathy. And I'm going to use the posterior tibial tendon as well as the Achilles tendon as examples, and then show you a way in which I tend to think about tendinopathy. So tendons normally will show a nice ovoid black appearance when you look at them on MR. And tendinopathy will generally end up showing a more heterogeneous and bright signal within it. In this case, you can see this is a fairly linear bright signal, and that is actually an intrasubstance split within the tendon. So you can see these splits. Obviously, somebody has a split, you want to see how much of the tendon is involved, because that gives you a sense of whether that split is an imminent rupture or if it's a small split that is likely to heal. We also look at the insertion, and when we look at insertional tendinopathy, it becomes very important for us to determine whether it's just tendinopathy or along with the tendon there is also bone involvement. So oftentimes when we see insertional tendinopathy, you will see changes in the bone, and I will talk especially bone marrow edema. And I'll tell you a little bit how we think about bone marrow edema associated with tendinopathy. Sometimes with the posterior tibial tendon, you'll see an accessory navicular. This may or may not have edema associated with it. And sometimes you will see no tendinopathy, but you'll just see fluid along the tendon. So you'll just see a tendon sheath effusion. So you can see synovitis. So as a variation, you'll see everything from normal to a split to insertional tendinosis to non-insertional tendinosis to insertional tendinosis with bone involvement to just a synovitis. When it comes to the Achilles tendon, you can see obviously just fusiform thickening of this Achilles tendon, which is non-insertional Achilles tendinopathy. You can see this more heterogeneous and diffuse Achilles tendinosis. You can see an insertional, so you see a small little linear split here, but you also see this insertional Achilles tendinosis, and along with it, you can see inflammation or edema in this bone spur or the Achilles insertional spur. Then you have the variation where you can see somebody who's got a Haglund bump. So you can see this very clear sort of spur over here with some deep retrocalcaneal bursal fluid, and along with that, some partial thickness undersurface tearing of that Achilles tendon. And then here you have a more discrete partial or full thickness tear that's non-retracted of the Achilles tendon. So these are the spectrum of changes that you would see in somebody with tendinopathy, non-insertional or insertional, with or without bony involvement, and with or without fluid. And this is sort of how I see the role of imaging in tendinopathy management. So if we look at a tendon, we want to see whether the problem is primarily insertional or non-insertional. If it is insertional, we want to look at the underlying bone. And if we want to see if the bone looks normal, and if there is bone marrow edema or no bone marrow edema. And remember, if you see bone marrow edema, it's important to remember that that's probably the tendon where you don't want to be aggressive in rehab and putting them through an eccentric loading program, because that bone marrow edema may just progress. And also, that's the patient in whom you, by injection, will deal with only the soft tissue inflammation, but you may not be able to do anything to the bony inflammation. So those are the patients in whom you're going to give a guarded prognosis on the effects of a possible injection if you do give one, or those are the patients you're going to put down the path of a more conservative management, saying, rest this bone, let the bone heal, and then we'll consider what to do going forward. On the other hand, if you have, whether you have insertional or non-insertional tendinopathy, you're trying to determine whether there's robust tendon, there's tendinosis, there's a partial tear or split, if it's a near complete tear or a complete tear. And if it's a tear, obviously we want to know whether there's a tear, where is the tear, what is the gap, what is the osseous size, what is the stump, what is the quality, because these are all the things we need to know if we're going to go in for surgery. On the other hand, if it is a robust tendon, then you're trying to determine whether you're going to give a paratenon or a tendon sheath injection of steroid, which can sometimes be controversial, or whether you're going to use something like PRP or an orthobiologic. And if it's a very attenuated or thin or not so robust looking tendon, then you're going to say, wow, should I really be doing anything to this, because I'm just going to push this tendon towards rupture? And in which case you're saying, let me push this tendon towards rupture because the only thing for this patient is surgery. So that is the decision step that you will make at that stage. On the other hand, once you finish looking at the tendon, start looking at the sheath or the paratenon. And if you see fluid, you may see just fluid. You may see synovitis. In other words, there's some thickening synovium in that area. And you may see tendon and synovium involvement. So if you see just fluid, it may be minimal and you may just want to conserve it. If you see synovitis, then perhaps you want to consider a steroid injection if there's synovitis but normal tendon. And on the other hand, if you see tenosynovitis, then do you sort of consider the role of PRP in these kind of situations? So in summary, what I've tried to do in the last about 45 minutes or so that we've been talking is talk about the basic MRI anatomy, the common structures that you'll encounter when we're looking at somebody with the ankle. We've talked about the common indications of ankle, acute ankle injuries, where we're trying to determine whether something is a low or a high ankle sprain. If it's a high ankle sprain, whether it should head to surgery or not. If it's a low ankle sprain, then why is that low ankle sprain looking worse than we would normally expect? And usually that would be related to the fact of a significant ligament rupture with pericapsular leakage, or because of an occult fracture, or because of peroneal tendon subluxation, or because of multiligamentous involvement. On the other hand, patients with chronic instability and chronic pain who come in, we're trying to determine if there is instability, what is the status of the ligaments, how well or poorly have they remodeled, what is the status of the articular cartilage, because if there's bad articular cartilage, then we're really not doing much of a favor to helping this person, or at least we can decide on what the prognosis for these patients would be once we do go ahead and fix the ligaments. And then we've talked about the fact of instability leading to micromobility, and micromobility promoting anterolateral, anteromedial, and posterior impingement. So we talked a little bit about that as well. And then last but not least, we talked about the fact of tendinopathy. And we talked about breaking tendinopathy into those different groups of insertional and non-insertional. And when we're dealing with insertional tendinopathy, whether we're dealing with something that has bony inflammation or bony irritation associated with it or does not. And if we do have bony irritation, then perhaps those are the tendons which we want to conserve and rest rather than put them on aggressive eccentric loading programs and injections. Whereas on the other hand, if you have no bony involvement, if you have a robust looking tendon, then perhaps you could consider orthobiologics. Whereas if you have an attenuated or weak looking tendon, then perhaps you want to conserve it or take them to surgery. And then we look lastly at the presence or absence of tendon sheath or paratenon fluid. If we just have a little bit of fluid, perhaps we just want to wait. If we have primarily synovitis, maybe we consider a steroid injection. But if we have tenosynovitis, perhaps we consider PRP. So with that, I'll stop this and open up our discussion onto the discussion section.
Excellent talk, Aditya. I learned a lot from your talk. I just wanted to know what is your protocol for tarsal coalitions, because I, in my practice, do see a lot of patients in their teens coming to me with pain and repeated ankle sprains. So, but finding out whether it is a bony or whether it is a cartilaginous or a ligamentous coalition. So, how do you go about it?
So I think when we're looking at coalitions, the primary test is always to get good radiographs at first. So appropriate frontal and lateral radiographs are important. Um, Sometimes, especially with the soft tissue coalitions, those can be hard to pick. But I think besides frontal and lateral, there's also oblique radiographs that are really helpful in terms of determining, especially the calcaneonavicular coalitions. Um, the next thing we would do is we pretty much do a routine MRI, but we do all of our MRIs with good resolution. And so we can see these really nicely on MR. And the other thing, if you wanted to determine whether you want to look for it a little bit more carefully, you can consider getting a CT. Actually, since I have you here, I actually had another talk which I was going to do on coalitions themselves, on flat foot. And so I can just show you the slide on coalition here. Um, so here is basically how well you can see coalitions. So this is, let me just see, let me just share my screen again. Um, so here is a slide that shows coalitions, and what you see on the sagittal images is this calcaneonavicular joint in this area, this little thing here, which would essentially be this. Why is this pen not working? Okay, here, pen. Okay, here. This little flat band here on the sagittal images, and this is the navicular coming here. So this area is the area that's very important on the sagittal images. And you can see in this patient with a coalition, you can see how there's that beak coming here. There's a little irregular area here and here. And then this on the navicular becomes like this with this little irregular area here and then another area here. And this essentially is your calcaneonavicular coalition, which is primarily osseous, but the last little bit is a fibrous bar over here.
Mm-hmm.
On the other hand, when you're looking at the coronal images, another area to look at is the sustentacular articulation. And normally the sustentacular articulation tends to be a horizontal line like this. Okay. But if you see angulation change in that sustentacular articulation like this, or you see like just partial fusion across that line, then that would be a key to somebody having a talocalcaneal coalition. And this is something that you can oftentimes see better, and these are situations where I think orthopedic surgeons prefer to have CTs because it gives them a better sense of how much is bone and how much is soft tissue.
Mm-hmm.
And that's just your way of thinking. You're just trained to look more at CTs, and because you can black and white tell bone from soft tissue. So I would say that then that's that. And with CT, the other things that you can do is you can potentially create 3D models now. You can do a bunch of other things that can help you make
But even when you are doing CT, you will miss the one between the calcaneum and the navicular.
No,
So
so you don't miss it, because you basically will change. You can change the angulation. You look at the area a little more closely. You can scroll through it a little bit more neatly. So
fibrous one that you just showed us.
Yeah. So again, the fibrous ones so what you'll notice in cases where you have fibrous coalitions, you will see that there's bony prominence. So there is some bony prominence, and also that articulation that you normally have in that area will have a change in its angulation. So those are two primary clues that are helpful in determining whether there is. So if you have a change in the normal angulation of the interface,
and
or if you have increased bone at that interface, those are two things that will clue you to that.
I was discussing it with my radiologist, and in one view you could see that fibrous band going there, but in the next view it wasn't very clear. So what would you do in that case?
So this is a question that we can talk about for hours until we see the images. I think the key thing here is to look at the images, and then I can explain those few things. But overall, yes, coalitions can be challenging to diagnose. We have seen many patients who are into their 60s who have coalitions. So basically, they've gone through life just fine, and you just notice it sort of later on in life. So they can be challenging. It's just a question of, especially in the younger patients, you want to pick it up sooner so that you can do something about it.
Yeah. Thank you. Thank you. Abhishek?
I think Aditya covered everything. I have learned everything from him, so it's really difficult. I think he's pampered me because now without, like, if I get scans from somewhere else, I have to find out where is Aditya and how can I do it. I think if I have to add one thing which Aditya could throw some light would be superior peroneal retinaculum. I think
Yes.
especially while looking at ankle instability, I think we as foot and ankle surgeon very often miss superior peroneal retinaculum injuries.
Okay.
And I think maybe that's something that we can always pick up on MR, or how to pick up those injuries on MR would help us kind of address them.
Okay, so
more.
let me show you a case here, and I'll just share my screen in a second, so I can show you the structure really well, and that should help you in terms of where just see that. Okay, all right. Let me just share my screen again. Okay, so these are two patients who have two different patients with ankle injuries. This one is this is the I'm going to flip this horizontally so that you see both on the same side. So this side is lateral. Can you see, Mama? This is lateral.
Yes.
Okay, so this is lateral here, and basically as we run down these are the peroneal tendons at the back here. So this is your longus, this is your brevis. These are the two tendons, and as you look back here, you can see this band of tissue here, essentially, which is this thing here, that. Okay, let me delete this. That is your peroneal retinaculum. And if you come up here and as you go down on this image, you will see this band of tissue here is the peroneal retinaculum. Okay, and essentially what you're looking to see is if there's edema or there is an abnormal signal. So in this case, you see some abnormal signal along this and edema along this. So this would probably be a low grade injury. But if you see discrete discontinuity of this, you see larger amount of swelling, then that would be something that would indicate that there's a peroneal retinacular injury. And as you go lower down, you'd get into sort of the inferior peroneal retinaculum. So this is basically your peroneal retinacula that you're looking at. Does that make sense?
Yeah, it does. I think the point I wanted to bring about is, like, as orthopedic surgeons, we should not miss these injuries, because very often in chronic ankle instability, as Aditya mentioned, the entire spectrum of chronic ankle instability, but again, peroneal tendon instability is also part of it. Sometimes you see a lot of them in teenagers, which we need to be addressed appropriately, or they can mimic ankle sprains, but they are primarily peroneal tendon subluxations than more of lateral ligaments.
Yeah, so I think they have managed to handle everything else, but the peroneal tendon is taken on more load. And so I think early identification of a peroneal retinacular injury is helpful in terms of preventing long-term peroneal tendinopathy and peroneal subluxation and instability.
And I think one more thing that I learned from Aditya while I was working under him was, I think, how to pick up osteoid osteomas. I think that's very important as a teenager. Like, clinical history would be there, but on MRs, if how to pick up these small tumors of foot and ankle, I think maybe another topic in itself, but maybe if you can just give us some pointers on that, that would be helpful.
Yeah, so I mean, I think for osteoid osteomas, one of the big things is you really need to have a clinical suspicion for it. The lesions can be quite difficult to identify at times. I'll see if I can find one of the osteoid osteoma cases in the ankle. See if I can find one in a second. But osteoid osteomas, usually if you see a very intense bone marrow edema pattern, then you should sort of be a little bit careful to make sure you don't miss an osteoid osteoma. And then go back and look at the story. If the story fits for somebody saying that, you know, they could potentially have a, let me just see if I have this. Unfortunately, I don't think I have this case readily available. So, in the interest of time, I'm not going to find it now. But if you see a fairly intense bone marrow edema somewhere in the neck, and you have symptoms of night pain, then then you, especially in the talus, then you've got to really look carefully for an osteoid osteoma. They're easy to miss. You'll see just bone marrow edema. You may mistake it for just a contusion. But if they have a story that goes with night pain, then you have to look very carefully, look with a CT. And sometimes these lesions can be very small and difficult to discern. So you really want to be careful about that. So osteoid osteo, I think anywhere in the body, I think the clinical history is the dead giveaway. Oftentimes they're very small. When they are intra-articular, they tend not to have that typical sclerotic rim and rounded appearance, and they just show up with a lot of edema and a joint effusion. So they can be very easy to miss in that sense. So unless you have a high degree of clinical suspicion, I've seen enough of these osteoid osteomas can be challenging.
Okay, great. Thanks, Aditya.
Thank you.
All right. Anything else you want to discuss? Any questions from anywhere?
Neeraj, do we have any other questions, like anywhere, like any chat or something?
Is he around?
Yeah, Neeraj is there.
मैं इधर ही हूँ, मैं कहाँ जाऊँगा? मुझे लगा तुम्हारा डिस्कशन चल रहा है.
हो गया.
Okay.
कोई और questions है आपको कुछ?
Yes, I have one question. So
Yes.
about the remodeling of the ligament.
Yes.
Can you just go back to that slide? That is something basically we no other radiologists have reported besides you.
So then it's wrong. For sure. Definitely it's wrong.
मतलब मेरे experience में मैं कितना ankle MRI कर रहा हूँ. I am not doing ankle MRIs left, right, and center. Na, I may be doing maybe once in 2-3 months.
Sure.
Or maybe 4-5 in a year.
I think when we talk about this ankle remodeling, let me just share the screen here. So when we talk about this ligamentous remodeling, really the point here is that it's when the ligament looks very close to normal ligament, it's a hard call to make. When it looks significantly thinner or attenuated, then we tend to go down the path of saying it is poorly remodeled. And the idea really being here is that MRI most imaging is not a great tool to tell that there is laxity. So when we say it's remodeled, we're just saying that it probably looks like a ligament that's not bang normal, but it looks a bit thinner or a little more attenuated than before. And so we would say whether it is in this case, with this grade 1 injury, where I would say this could potentially, like if this was a non-acute case, then I would say this is probably a reasonably well remodeled anterior talofibular ligament. Whereas this I would say is the grade 2 one I would say is a poorly remodeled anterior talofibular ligament. And if we go sort of to that case, to the later on situation where we see these. Here you can see this ligament is quite thin, and you can see how attenuated and thin it's gotten towards the talar attachment. So here I would say this is poorly remodeled because there's really not much of ligament here, but there is some fibrous tissue going across. So I think these are in a way just words that we use. And I think one of the things that radiologists have to be careful with using words is there are words that the orthopedic surgeons that we communicate with are aware of. So in our practice, we tend to work with a fair number of foot and ankle people. So, when we say something is well remodeled or poorly remodeled, they understand what we're saying. We're just trying to tell them that, yes, this person will probably have more instability or not have more instability. But the fact of the matter is the instability comes from not just the ligaments, but also the tendons and muscles around. So somebody could have a very poorly attenuated ligament, but may not be unstable because they've just got very good muscle tone around and they've done good muscle rehab and tendon rehab around the ankle. So you don't have that much instability. So it's just a way of telling the quality of the tissue really.
Yeah, but that is a very good thing, from the ankle sprain point of view, is where the patient is not becoming all right for a long time.
Right.
And we would really don't know. So I would like to share my screen and show you one MRI.
Okay.
Just let me know your little bit opinion on this. Let's see. No, not this. Let me share my full screen. Then that'll be better, I think. Yeah. So can you see this?
Yeah.
So which image do you want me to show T2?
So come down to this, to the PD image that is, come down one more. No, yeah, that one. Okay, now scroll down. So this is the syndesmosis. Now this is, now come down one more. Okay, so now this is the tib fib. Now come down even more, keep coming. Okay, come down, come down, come down, come down, keep coming, keep coming, keep coming. Okay, now go up. Yeah, okay, stop. Now up one more image, up one image. Down one more, down one more. Okay, see this area here anteriorly. You see that?
You can ask for remote control. I'll give it to you.
How do I do that? How do I ask for remote control?
You go in more.
Go into more, view options. One second.
Do you see any three dots? So below, niche you do see share screen, and share screen के बाजू में what do you see?
Record and reactions.
And उसके बाजू में कुछ नहीं है?
No.
Nothing.
I made you the co-host.
Advanced sharing options. Let's see what that is.
No.
I think if Aditya is on a MacBook, then I think it's on the top, not on the bottom side.
Top is speaker view. I have view options, and this I just have fit to exit full screen request remote control. There we go. Okay. All right. So here we go. So if you
Hold on. Yeah. Now you made it full black.
No, okay. So let me just do this. Hold on. Okay. So
just a minute, hold on. There is some window disturbing me of Zoom. I'll just remove that window first. Yeah, now you can go ahead.
All right. So just scroll down, yeah, to scroll down. I can't seem to scroll from
now,
this.
Now do it. Now you'll be able to do it.
Okay. All right. Okay. So first of all, when you come here, one of the things that you're going to be careful as you come down here, this you got to be careful. Could this be additional bone right over here?
Okay.
So you see this area here, this would be the ligament typically, but we just need to check to see if this could be bone. So we want to go onto these coronal images here, scroll back and forth. So you can see this come forward. Okay.
Yes.
See this is a small little piece of bone in the back here.
Yes.
Right. So this could be a small little bony avulsion that was there, which could be causing the impingement. So that is there for sure. So there has been an element of a bony avulsion. If we go on to the sagittal images and you move sort of to the back here, this is where the pain marker is. And you can see, one second. Huh?
Yes.
You see this piece? This is bone.
Right.
This is a bony avulsion here. So now it's not so much a case of now it's not so much a case of whether this ligament is attenuated or not, which is fine, but you've got a bony avulsion. And the question is, when you start to look at that bony avulsion or that bony area, you want to see if there's edema in that, because if there's edema in that bony area, then maybe you're dealing with somebody who's got an impingement of bone, which doesn't seem to be the case here. So here you've had an osseous avulsion with a very poorly remodeled ligament, because if you look at the ligament here, look at it, it's like very thin and attenuated, and below here there is bone, this piece of bone here. So this would be a poorly remodeled osseous avulsion of the anterior talofibular ligament from its fibular attachment. And so this is someone now, if you know, for a foot and ankle surgeon, they probably go remove that piece of bone. They'd want to look at the X-ray, obviously, to see what was there. And then they would consider reconstructing if this patient has instability. And some of that instability may be masked because of that bone impinging also. But before they did anything, they would want to see what is the status of his cartilage. So they'll want to look at sort of this cartilage here, zoom up and see, okay, fine, you know, this cartilage quality is quite good. So it makes sense for us to do something. Also, this patient has quite a bit of heel valgus. You look at this, there's like major subfibular impingement even here. So if you come back here, see how this area between this, so when this person loads, these two things will come together next to each other. So this patient will develop some subfibular impingement. There's also some heterogeneous signal in the deltoid here. So you know this person will also have some medial laxity. So this is a person you'll need to do some dynamic x-rays to see how much laxity there is. And then if they're going to operate on this, there is cartilage. So it's a good case to conserve. And then whether you're going to do just a lateral reconstruction or you're going to do some medial tightening as well would be sort of where I would reckon somebody would think about this case.
I took both of their opinions, the people who are with you in the panel. This was around 2-3 years back. MRI has been reported by you.
Okay.
So this MRI was done somewhere in NM Andheri, I think.
Yeah. Okay.
So both of them said almost the same thing, that she requires a lateral ligament reconstruction. So that was the only thing. And the only issue was that patient was not willing for surgery. The ligament injury was 10 years old and she's saying, मैं 10 साल से pain बर्दाश्त कर रही हूँ, मुझे आदत पड़ गई.
Yeah. So fair enough. And you know, she may even do well from, you know, she doesn't, if you look at the subcutaneous fat on her, she doesn't look like she's a very heavy set person.
Yeah, she's
so
very thin.
Yeah. So she may be the kind of person who just getting on, and she has an element of, probably has an element of flat foot. I can't, you know, it looks a little bit angulation wise like this. So she may be somebody who's helped a lot along the way. You know, the other thing we have to think about is are her symptoms coming primarily from subfibular impingement, or are her symptoms coming from the ankle instability?
So she is basically, I think there was tenderness, and I'll tell you what happened. So there was tenderness. I don't want to with the suspense. There was tenderness and there was a lot of instability. I even took videos and sent it to Rajat at that time.
Mm-hmm.
So, and she was quite unstable. So what I did is that basically she was not willing for any surgery, but she was having pain. That is the reason she came to me.
Right.
And so I gave her an injection, and since 2 years she has not come back to me.
Yeah, and you know, I'm not surprised, because I think that's the whole thing. When people have instability, the question is, what do you do about it? Do you deal with you can deal with the instability by working on the surrounding soft tissues, or you can deal with the instability by working on the ligaments. And if she's somebody who benefited by working on the ligaments, or if she just had some local inflammation and eventually she wasn't loading it as much, or she wasn't giving it as much, you know, if it wasn't something that she was majorly athletic or active or whatever else, then perhaps that's just good enough for her.
So right now the teachers are sitting and teaching, but she is basically a teacher. She's a teacher in a school.
Yeah. So, I mean, it just depends on what. I had teachers who just sat all day, and I had teachers who ran around all day. So I don't know which type she was. No. So
plus Aditya, maybe the impingement that you were discussing, that may have helped.
It may have. It's hard to say. I think in these cases, when you have the whole spectrum of things happening, so she has an element of flat foot, she has an element of ankle instability. The question is, what is the cause of her current symptoms? So she's a chronic. Yeah.
For 10 years, she's been managing. A little bit of pain relief would have helped.
Yeah. Eventually. So
it was a good discussion. There was one more case I was trying to find that I'm not able to get it. So when she came to me for the first time with an MRI, she only was, that is what I was telling you about the remodeling. So she was reported as having a cyst in the ankle, or something like, what do you call osteochondritis dissecans type of picture, where there is a cyst in the talus.
She didn't seem to have that much cystic.
No, not this case. I'm talking about another case now.
Yeah, okay.
Cyst in the talus.
Yeah.
And so I showed it to Rajat at that time. It was many years back. And that time he said that we can do just a microfracture thing arthroscopically, and that should resolve the problem.
Yeah.
Because I just showed him the MRI. I didn't speak about the symptoms at that time. Maybe I was not so aware.
Yeah.
Then she came to me again after a few years. Now you do another MRI, and I sent it to you.
Yeah.
And you reported that there is a remodeling of the ligament.
Yeah.
And this time I sent it to Abhishek, and Abhishek said that she might be having instability. Please examine her again. So I examined her, and then it found out that she had a lot of instability, which was maybe the cause of pain. Eventually, that patient also did not get operated.
So I find that most patients who have a talar osteochondral lesion, unless they are like under 15 years of age, or under 18 years of age, most of those patients, otherwise if they're a talar osteochondral lesion, it's usually a secondary or acquired talar osteochondral lesion, and that's usually because of chronic ankle instability. That's just been my experience. If you have them when they're younger, then it could be a primary osteochondritis dissecans lesion, in which case the instability issue wouldn't be that much and the primary issue is cartilaginous. But later on, I find that as you go later and later on, it tends to be because of instability. And maybe sometimes we overcall the ligamentous remodeling on the basis of the talar osteochondral lesion. You say, oh, we see that it's probably remodeled a bit. So, it's
So
scattered.
when we are on ankle sprain, I want to ask Rajat and Abhishek their opinion. When we do these chronic ligament injury reconstructions, do they actually become pain-free or only that reduces their instability maybe a little bit? I don't know. Do they actually become fully better or no?
Um,
That's like, oh yeah, no.
of course they do. They become 100% first class normal. We are gods over here of foot and ankle.
Listen,
We
which
make
orthopedic
everything normal.
surgeon, which orthopedic surgeon operates and patients don't get 100% better?
Yeah,
Exactly.
I want
That's
to
a
ask you
wrong.
this
That's a
question.
wrong question that he's asking.
Do they? Nahin,
And-
because I always feel these chronic pain patients whom we operate, at least not of the ankle joint, of the other joints I'm talking about, they somehow don't, maybe of the spine I'm talking about, so
I
they
think
don't somehow become 100% better. Their pain
think
reduces. Their
Abhishek
symptoms
knows
reduce.
my answer because Abhishek was here when we were doing this talk,
Hmm.
and I worked with a very senior guy, and he was father of foot and ankle, you can say, and then he was operating, and I couldn't see anything when he was.
Sir, you should not tell this story to everybody.
Okay, fine. So leave it then. leave it. Let's call it. Neeraj, I will talk to you later.
Okay, theek hai.
Sir, they do get better. Let's
do.
be diplomatic. They do get better,
I'm
and
sure
we
that
are
the
able to help
instability,
them cross
Yeah,
the bridge.
instability definitely improves, but I would make a point that what he would say, and even I try to see, if the cartilage is good, then only reconstruct. If your cartilage is bad, don't touch them.
Okay.
I
Because
think you've already missed the bus. I think,
Yes.
yeah.
So
If the cartilage is gone, then you
gone, don't
can't get
touch
them pain relief. You can get them stability, but no
Yeah.
pain
but
guarantee.
they
if
will
the
never
cartilage
be
is gone.
happy. Rather, wait for them and let them have arthrodesis later on.
It's like the ACL deficient knee with osteoarthritis. So you don't
Correct.
offer them ACL reconstruction.
Yeah.
Something like that.
Something.
So
Exactly.
I have seen one patient of mine, ATFL injury, which I had shared with Abhishek, but somehow that patient did not get operated by Abhishek and went somewhere else. He became quite good because that was an acute injury and he had a lot of instability. He had a really, basically his ankle used to subluxate every time he used to walk. And it was acute injury, means 1.5 months or 2 months. And then he decided, I should go for surgery. And his ankle, when he came to me for some other reason, or wife's back pain or something, that time he had completely improved.
I think his cartilage would have been good, sir, and that's why
He was a
I think
young,
he got
healthy bodybuilder type of chap.
Yeah.
Correct.
Okay. Thank you, Aditya.
I
So I
think
think,
fantastic.
all right. Cheers.
So
Thank you.
next week we see you for tumors.
Tumors, we'll get somebody else to talk about tumors. Those are important things, not for people like me.
Okay, so we'll decide the topic about next week, maybe a little later in the day.
Yeah.
Okay.
Sounds
Thank you very much. Thank you,
Thank you.
Rajat.
Okay.
Thank you, Abhishek.
Thanks.
Thank you.
Thank you. Bye bye.
Thank you.
Bye-bye.
Bye.